addressing her psychological support. Barriers fall into some broad categories: financial and economic, language and cultural, communication, the healthcare system, transportation, and bias based on culture, race, and age, as well as fear. Navigation must also factor in cultural competent care. Confidentiality is maintained for that patient. The patient is respected at all times, including if we disagree with perhaps what some of her cultural beliefs are. Compassionate delivery of care and services, and mindfulness of the patient's safety. We want to save lives. We want to eliminate barriers, and we want to ensure timely delivery of the resources. So who is responsible for performing these functions? And it doesn't always mean that it is a nurse, though the majority of the time, at least in the United States, it usually is. But it does depend on the environment and the factors. Everyone, though, I believe, who's involved with the patient at any level has some role and responsibility with navigation. This is not a process designed to be functioning in isolation. Whether it be recruiting that patient to come for a screening mammogram, or once she has a mammogram and an abnormality is found, getting her on to diagnostic evaluation, assisting at the point of biopsy so that she's educated about that, and then once diagnosed, getting her into the treatment system so that she can underway her consultations and have appropriate treatment. Oftentimes, there are some very basic steps that most navigators do. Meeting with the patient at the point of a suspicious finding or at the time that a diagnosis has been determined, and doing what I call a barrier assessment, identifying any barriers or potential barriers that that patient may have. Streamlining the appointment process and paperwork process so that that's not going to be a built-in delay in getting her seen and taken care of. Maintaining open communication with the healthcare providers, the caregivers, which may very well be her family members as well as the patient, and assist in increasing access to culturally appropriate and supportive care for her and her family, even linking the patients, the caregivers, and the family members up with appropriate follow-up services as well, and maintaining personal contact with the patient across the continuum. There are some situations in which a navigator is not a clinical person. There are individuals who are volunteers, and it's not unusual for that person to be a breast cancer survivor volunteer. The American Cancer Society has also created a program that is designed primarily for lay people to serve as an ACS navigator, and they have their own training program for it, and through grant awards are placing them, and have been for the last 4 years, into cancer centers. And as mentioned, the lay or survivor, and that seems to be a growing interest on the part of breast cancer survivors that want to give back in some way by supporting other patients who come along behind them. Social workers also are very appropriate and well learned to be able to fulfill this type of a task. But nurses are those who are primarily doing it, including advanced practice nurses, and in some cases, physician assistants. This particular graph was data collected by the Advisory Board Company, home-based in DC, and they have a division called the Oncology Roundtable, and conducted a survey of all of their membership in 2008, and you see how that's broken down, that the majority, 55%, are RNs, 20% advanced practice nurses. In doing some of their research of the Oncology Roundtable, they took a look nationally across the U.S. at cancer centers and put together what are the most common models of navigation that they saw. And for model 1 is where the majority of breast cancer navigation landed, so that it is a high volume, low acuity type of disease. For the countries that we've been talking about, though, for the last 2.5 days, I think that it would match up more so with a high acuity and high volume, which will make it the most challenging of all, I believe, to be able to fulfill. And, for example, pancreatic cancer is a category which is high acuity and lower volume. The potential benefits that we can measure the effectiveness of the navigation program: improved coordination of high-quality care, enhance access to the services for all patients, removing the barriers that we've talked about, making sure that the care is delivered in a more efficient manner, improved survival outcomes and other clinical outcomes, improved sharing of resources, enhanced relationships with the community, increased patient satisfaction, I also would say family satisfaction as well, and increase in referrals of new patients into the system. More efficient delivery, for example, could be measured by measuring the time delays between a screening mammogram and going on to a diagnostic mammogram, and from there on to biopsy, and having those pathology results back. Another measure in time delay is the confirmation of breast cancer found on a core biopsy to when that patient is initially seen for a surgical consultation and then goes on for the actual surgery to take place. Improving outcomes, adhering to the NCCN treatment guidelines. What percentage of patients did receive radiation following breast-conserving surgery? The percentage of patients receiving chemotherapy who had stage 2 or stage 3 breast cancer, the percentage of patients receiving hormonal therapy whose tumors were hormone receptor positive. And enhancing relationships with the community. Examples of that is the use of community resources and having them carefully tracked. Recruitment of patients for screening mammography from the community by forming relationships with PCPs and other awareness groups. There is a study that I was able to review and chose to also include in this PowerPoint presentation, looking at some ways that some facilities have validated the benefit of navigation. This case study example was measuring a patient population that was in an urban minority group who had abnormal mammograms, and the objective was the need to expedite faster delivery of diagnostic results, lower anxiety level of the patient, and have her have greater satisfaction with her care. And the results showed that women who were helped by a navigator, in this case it was a nurse navigator, had shorter times to diagnostic resolution, and only 6% of women in the intervention group were still waiting for a diagnosis at 60 days. Now, it broke my heart when I saw 60 days. But you have to start somewhere, right? And I grew up being a 4-H'er as a youngster, and their motto is make your best better. So wherever your best is today, it's okay. The objective is to make it better. Women who were helped by the navigator also had shorter times to diagnostic resolution. You see 25 days when previously it was almost 43. And the navigator group had a lower mean anxiety score, which I thought was wonderful to see, previously on a scale of 0 to 10 being an 8, and it was reduced to 5.8.